Hello, friends. I am super excited to be here with you today to give you this lecture on the TMJ. And so the TMJ is one of those things that can be very daunting. I remember studying and looking over the TMJ, and initially when I looked over, it's one of those things where I was like, well, I guess I'm just getting all the questions on the TMJ wrong. And it's very confusing and can be a difficult subject to study. So my purpose for this lecture is to streamline things and demystify the TMJ. So just a quick outline here. The first part, we're going to go over the structures of the TMJ. In part 2, we're going to go over the ligaments. In the third series, we're going to go over muscles. Part 4, we're going over pathology. And then in part 5, we'll go over the blood supply and the innervation. And so you'll see questions really coming from these main structures right here. First one is the temporal bone, and there's two parts here that we want to know. There's the mandibular fossa, and then there's the articular tubercle. And then there's two synovial cavities. There's a superior joint cavity, which sits right above the articular disc, and then there's an inferior joint cavity, which sits right below the articular disc. Then we have the articular disc. Sometimes it's called the articular capsule. Then we have the retrodiscal tissue, which is connected right behind the posterior portion of the articular disc. And then we have the condyle. So just a quick note on embryology. The main question you do get is at which stage the TMJ is going to be kind of done with its development, and that's 12 weeks. And then the second most common question that I've seen is at which week is the articular disc forming? And that's going to be 6, 7, and 8. So there's 3 stages in the development of the TMJ. There's the first stage, which is the blastemic stage, which occurs at weeks 7 through 8. The cavitation stage at weeks 9 through 11. And then the maturation stage at week 12. And I like to think about this in terms of a cavity. So think about the first molar comes in at age 6. So by age 7 to 8, that first molar is blasted with cavities. By age 9 to 11, that cavity is becoming cavitated. By age 12, it's a very mature cavity. So for the first part, we're going to look over the condyle. It's the part of the bone that articulates with the articular disc. And so this picture is showing the mandible right here. So the condyle is the posterior part of the mandible. And you'll get a couple of very specific types of questions about the shape of the condyle. So here we're looking at the condyle from the top. The condyle is asymmetric. It has a lateral pole and a medial pole, which tells you the direction that it's facing. So the lateral pole is that part of the condyle which is closer to your ear, and then the medial pole is that part of the condyle which is closer to the middle of your head. So if you put your finger in front of your ear and just kind of open your mouth a little bit until you can feel that joint, you're feeling the lateral pole of the condyle. If you look at the shape of the medial pole, you'll see it's more prominent and the lateral pole is much more blunted. And for some of these things, I'm going to be using terms like the articular disc, which we haven't studied yet, but we'll study in a couple slides. So for some of this stuff, I just wanted to wash over you. Just listen to it for the first time, and you can always come back and listen to the lecture again after you've seen everything. So the articular disc is actually sitting on top of the condyle, and it is thicker at the medial pole. You'll see a lot of questions come up on the shape of the condyle. It has an elliptical shape. Sometimes you'll see that as a football or an oval shape. And so if you see here, looking at it from the top, it's shaped like a football or an elliptical or an oval shape. When we look at the disc from the front, it's concave. And so there's this little dip. And then if we look at it from the back, it's convex. So I usually will remember that the shape of concave is like the inside of a disc by remembering the word cave. And so a concave shape looks just like a cave. This articular disc is going to get divided up into 3 sections. There's the anterior, the middle, and the posterior. And this condyle will articulate with that middle part of the disc. They usually will call that the intermediate zone. And we're going to cover that in the next couple slides. By the end of this lecture, you're going to be an expert at this stuff. Sometimes you'll see the, questions about which skull bone the condyle articulates with, and it articulates with the temporal bone, more specifically, the mandibular fossa. We mentioned the mandibular fossa earlier. Sometimes you'll see different names for the mandibular fossa. Sometimes you'll see it called the articular fossa or the glenoid fossa. So for the format of these lectures, I'm going to go over just a summary of the facts that you need to know, and then some types of questions that you'll see come up pretty frequently. You'll see this question come up about the symmetry of the condyles. So the condyles are not symmetrical nor identical, true or false. And that's true. Remember, the lateral pole is blunted, the medial pole is more sharp and pointed, and that's where that articular disc is going to be a little bit bigger. Remember, the condyle is elliptically shaped or football or oval shaped. And if you look at the long axis, it's oriented mediolaterally. When we look at the condyle from the posterior, what is this shape? It's rounded and convex. The anterior-inferior aspect of the condyle is concave shaped. So they'll try to confuse you with all these weird directional terms, and all you're really looking for is the anterior. From the anterior, it's concave. From the posterior, it's convex. The condyle articulates with which part of the articular disc? The intermediate zone. So now let's look at the articular disc. Sometimes you'll see it as the articular capsule. So the main questions you'll see is what is the composition of the disc, and then questions about the three portions of the disc, or the three zones. And so the disc is composed of dense fibrous connective tissue. There's three zones. We divide it up into a posterior band, an intermediate zone, and an anterior band. They like to ask you what is the posterior connected to and what is the anterior connected to. So the posterior is connected to something called retrodiscal tissue. And the name just tells you that. So retro is behind and discal is the disc. It's attached from behind the disc. This tissue is highly vascular and innervated. That's another question you see come up a lot. So you got to know that the retrodiscal tissue is highly innervated and highly vascular. This is the thickest part of the band. And so the PB for posterior band is thick like peanut butter. And then the intermediate zone is going to be the thinnest part of the band, and it's where the condyle sits. And so that's going to help us remember that it's the thinnest part of the band. So the intermediate zone is where the condyle sits, and so it's squishing the band right there, making it thin. And then this part of the band is avascular and no innervation. And so we're going to use the condyle sitting on the band to remind us about this fact also. So because the condyle sits right there, it makes it super thin, and then it squishes it to the point that it can't receive any nerves or blood supply. And then the anterior band is going to be connected to the discal ligament, the lateral pterygoid muscle, and indirectly the condyle. Really, you see the most questions come up on this intermediate zone, and then next the posterior band, and then the fewest amount of questions is going to come up on the anterior band. Pretty frequently you'll see this question come up about which part of the TMJ is not innervated and has no blood supply, and which part of the TMJ is highly innervated and has a very extensive blood supply. And so I have this intermediate zone highlighted in blue because it's going to remind us that that is avascular, has no blood, has no nerves. Remember that condyle is sitting on it and squishing it to the point that it cannot have any nerves or blood in it. And then that retrodiscal tissue is attached to the posterior band, highly innervated, and has a very extensive blood supply. And then on this anterior band, this is a good picture to see that it's attached to the lateral pterygoid, and specifically the superior head of the lateral pterygoid. I don't want you to worry too much about that because we're going to focus on that pretty extensively in the muscle lecture. The articular disc sits between the condyle and the mandibular fossa, sometimes called the glenoid fossa. Sometimes you'll see it as the articular fossa. This will divide the joint into a superior cavity and an inferior synovial cavity. So in this picture, you'll see that there's a synovial cavity on the bottom of the disc and a synovial cavity on the top of the disc. And again, remember that this is formed at week 6, 7, or 8 of embryo development. Is the posterior band thicker where it lays on the medial pole or the lateral pole of the condyle? And that's going to be the medial pole. What kind of tissue is attached to the posterior articular disc? Retrodiscal tissue. What is the middle part of the articular disc called? And that's the intermediate zone. What nerves and blood vessels supply the intermediate zone? And that is a trick question. It's avascular and lacks innervation because that condyle is squishing it to death. And then what type of tissue is attached to the anterior band of the articular disc? And that's going to be the collateral ligament, the superior belly of the lateral pterygoid muscle, and indirectly the condyle. Which part of the TMJ is avascular? And that's going to be the intermediate zone of the articular disc. Which part of the TMJ is highly vascular and highly innervated? The retrodiscal tissue. So make sure that you don't pick the posterior band, because that can be a little bit confusing because it is attached to the retrodiscal tissue, but it's actually just the retrodiscal tissue that's highly innervated and has an extensive blood supply. You want it to be innervated because if that disc slips back too far, you want to know about that. And so that's the body's warning sign that the disc is about to slip. We don't want it to slip too far back. It's going to squish into that retrodiscal tissue. That's going to hurt, and will compensate by bringing our joint forward. Okay, in this one, we're going to cover something that can be very confusing. So we have the articular disc, and then we have this other thing called the articular surface. So the articular disc is this thing we've been talking about, and then the articular surface is part of the bone, and it's the part of the bone that touches the joint. And think of the name here. The articular surface is the part of the bone that articulates with the joint. And so we have two articular surfaces that we're keeping track of. We have the articular surface of the mandibular fossa, and then we have the articular surface of the condyle. So there are 4 layers to the articular surface, and that goes for all joints. And in the TMJ, we see an exception to what most joints have in their 4 layers. So there's 4 layers, so that means there's a superficial layer, which is going to be closest to the joint. And most joints' superficial layer is going to be fibrocartilage, but the TMJ's outer superficial layer is made of dense fibrous connective tissue. And does that sound familiar? Well, that's what the articular disc is made out of. So the articular disc is made out of dense fibrous connective tissue. The superficial layer of the articular surface of the mandibular fossa is also made of dense fibrous connective tissue. So let's look at these 4 layers. So the superficial layer is called the articular zone because it's that zone that articulates with the joint. And in the TMJ, it's made out of dense fibrous connective tissue. In most other joints, that's made of fibrocartilage. And we use this joint so frequently and so much that if it was fibrocartilage, the joint would wear out. We want something a little bit stronger, and so that's why we want to see dense fibrous connective tissue right there. The second layer is going to be the proliferative zone, where all the cells are, and then the third layer is going to be the fibrocartilaginous zone. So here you see we have to be really, really careful because they can ask some tricky questions about this. And so you have to be very, very attentive to these types of questions and really, really understand this exception that most joints, the superficial layer is fibrocartilage. The TMJ is an exception to the rule. It has dense fibrous connective tissue, yet it does have fibrocartilage in the third layer. And so you can bet that they're going to use that to try to confuse you. And then the last layer is the calcified cartilage zone. So these articular surfaces of the bone are going to receive their nutrition from the synovial fluid. And remember, there's an upper and lower compartment. So it's important to know that that mandibular fossa receives its nutrition specifically from the superior synovial cavity, and then the condyle receives its nutrition specifically from that inferior synovial cavity. Okay, so let's get to some questions. On these ones, we're going to focus on dense fibrous connective tissue. What structure is composed of dense fibrous connective tissue and is positioned between the condyle and the fossa, dividing the joint into superior and inferior spaces? And that's going to be the articular disc or the articular capsule. What is the superficial layer of the articular surface of the TMJ covered with? And sometimes you might see it more specific, asking about the condyle or the fossa. And that one's pretty easy. It's the exception. Remember, we're reminding ourselves that the capsule is made of dense fibrous connective tissue, and so is that superficial layer of the articular surface. We need something strong that can withstand a lot of movement, force, and use, and not wear out like fibrocartilage. What is the superficial layer of the articular surface of most joints covered with? Fibrocartilage. So you have to be very, very careful on how you read these questions. Because if they're asking about the TMJ, this answer would be dense fibrous connective tissue. And if they ask about what's contained in the third layer, of the articular surface of the condyle or the TMJ, it's going to be fibrocartilage. If they ask about the first layer of the articular surface of most joints, it's going to be fibrocartilage. You got to pay attention to which layer they're asking about and which joint they're asking about. So in this slide, we're going to be focusing on that temporal bone. There's two parts you got to keep track of, the mandibular fossa and the articular eminence. So remember, you'll see the articular fossa with three names. Sometimes it's also called the mandibular fossa. Sometimes it's called the glenoid fossa. So this is part of the temporal bone. It's where the condyle articulates. It is thin and it is non-functioning. So that's just where the TMJ sits. So when the TMJ is moving and acting, the disc is slipping over the articular eminence. It slips forward, and so the articular eminence is where all the action happens. When the disc isn't doing anything and it's just still, you're not talking, moving, or eating, it's just sitting right in that mandibular fossa. When the joint is being used, that disc is slipping over that articular eminence. So the articular eminence is also part of the temporal bone. It's just in front of where the condyle sits, and so it's closest to that anterior band. This is a thick part of the temporal bone. It's the functioning portion of the TMJ. It's where all the action and sliding occurs. And dislocation is when this disc slips too far forward and gets stuck in front of that articular eminence. There's a little bump right here, and if that disc moves too far forward, it gets stuck right in front of that. That's called dislocation of the TMJ. The articular surfaces of the condyle, or more specifically of the mandibular fossa, are covered in 4 distinct layers that we just talked about. The most superficial layer is the articular zone, and remember that's dense fibrous connective tissue. The second layer is the proliferative zone, where all those cells are. The third is the fibrocartilage zone, and then the last layer is the calcified cartilage zone. And remember, the articulating surfaces get their nutrients from the synovial fluid, and you have to kind of pay attention to which bone they're asking about. You know, they're asking about the temporal bone, or are they asking about the condyle? So let's go into some questions you can get on the temporal bone. So what is considered to be the non-functioning part of the TMJ or temporal bone? And that's going to be the articular fossa or the mandibular fossa or the glenoid fossa. The mandibular fossa and the articular eminence are part of which skull bone? And that's going to be the temporal bone. And if you put your fingers on your temples, you can use that to remind yourself, because that's right where the TMJ is. If you put your fingers on your temples and then open your mouth and then kind of slide your finger around a little bit, you'll start to feel your joint right up there by your temples. And then questions you'll see on the articular eminence are going to focus on it being the functional part of the TMJ. So what is considered to be the functional part of the TMJ? The articular eminence. Which structure sits just above and in front of the anterior zone of the articular disc? And that's going to be the articular eminence. Dislocation of either or both the TMJ can occur when the condyle translates too far anteriorly past the crest of the articular eminence. And then where do the articular surfaces of the TMJ get their nutrition from? And that's going to be the synovial fluid. So let's go over the retrodiscal tissue. This is going to connect to the posterior band of the articular disc. It's highly innervated and vascular. It's the source of proprioception for the TMJ. Remember, that's where the nerves are, and if the band goes too far backward, we kind of want to know about that so that we can correct it. We don't want the disc to slip too far out of place. And because we don't have that tissue on the front, unfortunately, that disc can slip too far forward. We don't have that sense of proprioception, and we can get dislocation when that disc slips anterior to the crest of the articular eminence. So I think it's worth going over the different types of connective tissue again. So right here, I've organized all the different connective tissue questions. So remember, the superficial layer of the articular surfaces of the condyle or fossa are composed of dense fibrous connective tissue, and that's the exception for the TMJ. And then the third layer is composed of fibrocartilage. And then the articular surfaces of most joints outside of the TMJ is going to be composed of fibrocartilage. The TMJ gets so much use that it has to have a really strong connective tissue like dense fibrous connective tissue to support it. So which component of the TMJ has the most vasculature and innervation? And that's going to be the retrodiscal tissue. What is the source of proprioception in the TMJ? That's going to be the retrodiscal tissue. What type of connective tissue is in the tissue that connects to the posterior band of the articular disc? And that's going to be loose connective tissue with blood supply. And I don't know that I actually mentioned that. Retrodiscal tissue composed of loose connective tissue. And it's attached to the articular disc, which is composed of dense fibrous connective tissue. And it is connected to which zone of the articular disc? And that's going to be the posterior zone. And that's the end of the lecture on structures. Next one is going to be ligaments, which can be very confusing, so make sure that you tune into that. I hope that you have learned a lot from this lecture here. I really think that if you know all the stuff I've gone over in here, go over it a couple times, oh man, it's going to be such a relief for you when you take this test. You're going to know all these questions. TMJ is going to be super easy for you. And so I'm so excited for you to have this resource. I wish I had this, to study when I was looking over the boards. It just streamlines everything. I hope it simplified the TMJ for you, and I'll see you in the next video. If you like this lecture, please consider checking out my course where I provide the entire lecture on the TMJ and, the rest of the 200 facts that if you watch and understand, you're going to fly through these questions super fast and easily. And the TMJ is just going to be a breeze for you.